important. Yeah.
Okay. So Moong, let's start. I'm going to ask everyone to introduce themselves first.
Yeah. So maybe I'll start. So my name is Moon. I'm working with NACO with the TI division. Thank you all for joining.
Okay, good morning everyone. Myself, Wilson Doding, in charge TI and an OST from Meghalaya.
Yeah, Dr. Christina, maybe you can introduce yourself.
Hello, I'm Dr. Christina from ODIC Dangan Dimapur.
Hello, Christina.
Hello.
Next, Dr. Angela. Dr. Angela, can you introduce yourself, please?
Hello, I'm Dr. Paswet, OST Center Joy.
Okay.
Hello, Dr. Angela. It's good to have you here.
Okay, well, thank you.
Yeah, Dr. Lamare. Dr. Daya Banki Lamare. You can introduce yourself. After that, we have Dr. Easter.
Dr. Janet is there. Dr. Janet.
Yeah, I'll just request all of you to introduce yourselves. It's difficult to pronounce the names, so just mute yourself and please just introduce yourself. Thanks.
I'm Dr. Marang from OST Center, Newland, Dimapur.
Hello, I'm Dr. Yube, OST Center, Parent, Nagaland.
Hello everyone, I'm Sweetfully Kharsano, staff nurse from Civil Hospital Nongpo, Shillong, OST Center.
Good afternoon, everyone. I'm Easter Joy Karbuli, OST staff nurse, Civil Hospital, Knoxton.
Hello, I'm Dr. Taito from Civil Hospital, Dimapur.
Hello, everyone. Good evening. I am Dr. Janwarius Nongtudu from OST Cleary.
Hello, I'm Dr. Janet Marvin from Viham, Shillong.
Anyone else? Is there anyone left?
Okay, if everyone else is done, then I will introduce myself. I'm Dr. Gayatri Bhatia. I have done my MBBS MD Psychiatry from AIMS New Delhi, and I did my DM AIMS New Delhi, and I worked with NACO in 2021. Currently, I am Assistant Professor in Department of Psychiatry at AIMS Rajkot, which is in Gujarat. I'm very happy to be connecting with all of you once again. And let's start with today's session. We received refresher courses and trainings for opioid substitution therapy starting from 2021 when the guidelines were revised. So the purpose of this event is to briefly go through all of the new guidelines and the changes once again, to refresh ourselves with what is opioid substitution therapy and to answer all the questions that you may have in your daily practice. So without further ado, I will start sharing a few slides. Please feel free to stop me whenever you have doubts. And can you hear me?
Yeah, Doug, we can hear you.
Okay, so this is going to be an interactive session and I'm going to need answers from all of you. If you don't ask questions, then I will ask questions. So please be attentive and please don't hesitate to ask. Let's get started. Okay. So today we are going to discuss what is buprenorphine-based opioid substitution therapy. We will be covering opioid substitution therapy in these following brief headlines. We'll talk about the basic philosophy of opioid substitution therapy. We are going to discuss buprenorphine's pharmacological properties. We are going to also discuss why buprenorphine is an ideal OST medication, and then we are going to discuss some case scenarios. So when we talk about opioid substitution therapy, as the name suggests, the philosophy lies in replacing a drug of abuse with an opioid agonist. So what we are essentially doing is we are replacing the drug of abuse or the drug of misuse that the patient is engaging in, for example, morphine or heroin or smack or afim or whatever local preparation of opioids that the person is using, with a medicated preparation called buprenorphine. Essentially committing an illicit, unsafe drug to a legal and safer alternative. Some other added benefits of opioid substitution therapy are that a short-acting drug is replaced with a long-acting drug, a more addictive drug, and something that may or may not be pure and may be taken by injection route, having a risk of overdose, is being substituted by a medication which has known purity, known concentration and potency, whose dosing can be controlled, and along with all the risk factors that are eliminated, OST also provides for psychological and psychosocial interventions. So overall, the person's life is improved. When we talk about buprenorphine, the drug of choice for OST, it is essential that we understand how OST and how buprenorphine in particular works. If we look at this graph, looking at the known opioid antagonist that we have, that is naltrexone, it does not have any opioid-like effect on the mu receptors. So no matter how much dose you give, the effect is going to stay the same. And when we talk about the pure opioid agonist, for example, morphine and heroin, the greater dose you take, the greater is the opioid effect. So if you take very high doses, then you will have very high opioid-like effect. If you take low doses, just a small amount of euphoria you will get. Somewhere in between is a partial agonist, which is buprenorphine. What it does is, when you increase the dose to a certain extent, there is increase in opioid effect in proportion. But beyond a certain limit, if you give higher dose, there is no increase in opioid effect. So the opioid effect stays the same even if you keep increasing the dose. So it has a full opioid-like action at lower doses, and at higher doses, even when the dose increases, the effect of opioid will stay the same. And the point at which the opioid effect stops increasing with continued increase in the dose is called the ceiling effect. This is a very unique property of buprenorphine, that after a certain dose, there is no increase in the pharmacological effect, making it a very safe drug for unmonitored admission as well. How do we translate this into our clinical practice? When we talk of a partial agonist, the effect of having an opioid-like effect on higher doses is low. And as we know, opioids are related to respiratory depression. So with a limited opioid effect, the chances of having respiratory depression even at higher doses are minimal. That means rarely an overdose will occur and the chances of death are reduced. Let's talk about the mechanism of action of buprenorphine. Buprenorphine has a high affinity towards the mu opioid receptors, which are responsible for the high that patients who take morphine as well as heroin get. So it binds to opioid receptors with more tightness as compared to heroin, morphine as well as methadone. What it does is it will bind it with greater tightness. So if a receptor is free, buprenorphine will occupy it and will not allow any more opioids to act on the same receptors. And if the receptor is already occupied by other opioids, then buprenorphine will displace the opioid and take its place on the receptor. So these two activities will occur. That is, if the person has already taken some opioids, then buprenorphine will replace it and bind itself. And if the opioid receptors are free, then the buprenorphine will sit in the receptor and will not allow any other opioid to take its place. So buprenorphine will have its own opioid-like effect and will prevent any other opioid from having their effect as long as it is there with the receptor. This means that if the person is under the influence of heroin and you administer buprenorphine, there will be a net decrease in opioid effect because heroin is a full opioid agonist. And now we are giving a partial opioid agonist. Once that happens, the net opioid amount in the body reduces and the person who will not be having withdrawal earlier can have opioid withdrawal now. So this withdrawal, which is precipitated by giving buprenorphine, is called a precipitated withdrawal. Again, if the individual is on a daily dose of buprenorphine, that means the receptors are fully saturated by buprenorphine daily dose. If the person happens to take heroin on top of buprenorphine, heroin will not be able to bind to the mu opioid receptor because buprenorphine is already sitting there and it will not allow the heroin to act. So the person will not have any intoxication added with heroin. This is called the opioid blocking effect. These two effects are actually made use of when we give OST in daily dispensing. Also, buprenorphine dissociates with mu opioid receptors very slowly. This means that after administration of buprenorphine and after the action is done, it takes around 24 to 37 hours to eliminate from the body. Most of the heroin and morphine that people take, they dissociate from the body within 6 to 8 hours. So you must have seen that the patient that come to you take heroin or morphine around 3 associate. That means once daily with buprenorphine, but not with any other opioid. So this means that at low doses of buprenorphine, the effect can last up to 12 hours. And at high doses, that is around 16 milligrams of buprenorphine taken together, the effect may last up to 48 hours. This clearly means that once daily or alternate daily dosing of buprenorphine is possible. This means that the person gets extra time to focus on the rest of his life rather than just pursuing buprenorphine or in preoccupation with using another drug. When we look at pharmacokinetics, we know that there are 4 means in which buprenorphine can be administered: an oral tablet, a buccal film, sublingual tablets, as well as intravenous injection. If we look at bioavailability, the bioavailability for sublingual is 50% and that for intravenous, of course, is 100%. And the mean elimination of half-life of intravenous buprenorphine is 3 hours and that of sublingual buprenorphine is 27 hours. So if we compare all of these, we understand that sublingually given buprenorphine has a good bioavailability and has a good elimination half-life. So this forms the ideal way of giving buprenorphine to a patient. When we talk about contraindication, there is only one absolute contraindication to buprenorphine, that is a hypersensitivity reaction to buprenorphine in the past. Otherwise, in most other cases, buprenorphine is well tolerated and can be given safely. But we must apply caution when we give concurrent use of high dose of sedative hypnotics, that is benzodiazepines or alcohol along with buprenorphine, because of the risk of respiratory depression. Both of these groups of drugs have added respiratory depression, which may enhance their effect along with buprenorphine. So this is one case that we need to warn our patients about, that if you are taking alcohol with buprenorphine, please be careful. There is risk of death by respiratory depression. So in patients with asthma, there is increased risk of respiratory depression because their airway is already reactive. And in case of hepatic impairment, we need to maintain caution because sometimes buprenorphine's levels may become erratic in the blood due to erratic metabolism. When we look at drug interactions, it's a relatively safe drug by and large. There are minimal interactions with other drugs. However, it is often the case that many other drugs are co-administered with buprenorphine, the commonest being benzodiazepines. For example, for benzodiazepines, the most common drugs being given along with buprenorphine are lorazepam and diazepam. Now, both of these drugs will have a cerebral depressant effect. So that is something that we need to take care of, that we optimize the doses so that the patient does not have respiratory depression and cerebral depression. And if buprenorphine is taken along with pure opioid agonists, then the risk of precipitated withdrawal is always there because the net amount of opioid in the body will go down due to partial agonist action of buprenorphine. As we have discussed earlier, we need to be careful and warn the patient with co-administration. Now, there are common medications which are actually enhancing or reducing the effect of cytochrome P3A4. That is the enzyme system from which buprenorphine gets metabolized. So the enzyme inducers generally tend to increase the activity of the enzyme, making buprenorphine very rapidly metabolized. And in these cases, the buprenorphine dose needs to be increased. These are the examples of common drugs that we give along with these patients that you might encounter is carbamazepine, efavirenz, and nevirapine, which are commonly used with patients in HIV. So whenever these drugs are given, buprenorphine dose may have to be increased because of its rapid metabolism. Conversely, there are certain drugs which inhibit the enzyme, and thus the buprenorphine effective dose needs to be decreased because its metabolism has slowed down and may lead to buprenorphine toxicity. So fluoxetine, fluoxamine, and paroxetine are common antidepressants that often these patients are given along with antiretrovirals like ritonavir and indinavir. Now, once we are aware that these drugs are being co-administered to the patient, it is important that the dose of buprenorphine be decreased accordingly so that the patient remains comfortable and there are no other drug interactions. When we talk about buprenorphine's dependence and abuse potential, buprenorphine, yes, can be abused and is often abused. So we often take chances and prevent diversion of the drug in our day-to-day practice. People who are non-dependent on buprenorphine may produce euphoria and may cause a certain amount of dependence because withdrawal symptoms might occur after abrupt cessation of repeated dose of buprenorphine. However, the abuse liability is much less when it comes to heroin as well as morphine. So if a person comes and asks you, ma'am, I was dependent on on heroin. Now I'm dependent on buprenorphine. As will commonly happen to you, you have to explain that heroin is a drug of abuse while this is a treatment. Now, what makes buprenorphine our drug of choice for opioid substitution therapy? There are certain properties that buprenorphine has uniquely because it has an action similar to an illicit opioid but is able to control withdrawals and cravings. So, once the patient is on this medication, ideally they will not have buprenorphine related withdrawals and they will not have any opioid cravings. Addiction potential is lesser as compared to other drugs. It is easy to administer. Sublingually is very easy. Action lasts for more than 24 hours. Is well tolerated. Minimal drug interactions and minimal adverse reactions. So I will take a break here and I will ask if you have any questions so far. Please unmute yourself and ask questions. You can also ask questions in the chat box.
Can I have a question, ma'am?
Yes, please.
Could you please explain again the precipitated withdrawal?
Okay.
Yeah.
Precipitated withdrawal usually occurs when the person is dependent on an opioid agonist and buprenorphine is given on top of that agonist. What happens is, here, we have studied about two properties of buprenorphine. That is, buprenorphine A is a partial agonist and B, buprenorphine displaces other opioids. So if the person has taken heroin, suppose the person took heroin 1 hour before coming to your clinic. He is not in withdrawal right now because he is intoxicated. And if you give buprenorphine now, what will happen is buprenorphine will displace the heroin which is placed in the mu receptors right now. But heroin is a pure opioid agonist and buprenorphine is a partial opioid agonist, right? So the net dose of the net dose of the opioid in the body will reduce from pure agonist to partial agonist. Some effect will be lost. Now, once that happens, since the dose of opioid in the body is going, the person will have withdrawal. This is called precipitated withdrawal because this is the withdrawal that you have induced as a doctor.
All right. Thank you, ma'am.
I hope I'm clear now. Is there any more questions?
Ma'am, just go to the next slide. I think I missed the next slide after this.
Okay, sure.
Just this.
Janet, your voice is breaking up. I can't really hear you. Janet, can you hear me? Are there any more questions? Okay. That's a good question. Can there be an overdose of buprenorphine? It's very rare to see an overdose related to buprenorphine because it has a ceiling effect. Around 32 milligrams of buprenorphine, from 24 milligrams of buprenorphine to 32 milligrams of buprenorphine, it has been observed that if we increase the dose, just the dose increases, the impact of opioid effect does not increase. So it is very rare to have buprenorphine overdose because the ceiling effect of the buprenorphine will not cause any more respiratory depression or any more opioid effect. Any more doubts or questions or clarifications?
Ma'am, one more thing.
Yes, please.
Like you said, it's possible to use the drug alternate day if we give a higher dose, right?
Yes.
So practically, sometimes it's very difficult for certain patients because of certain problems to come every day. So sometimes is it logically, practically, is it possible to increase the dose a little bit so that they come alternate day?
That
that is
can
not
be
allowed.
possible. Theoretically, it's possible, but under NACO's OST policy and program, it is not admissible.
Not allowed.
Not
Yes,
under
yes.
NACO, but if there are other programs that are running, or if it is a private practice that somebody is doing, they can.
Okay, okay. All right. Okay. Thank you, ma'am.
There's another question Dr. Flora has asked. Doctor, can you clarify what is the maximum dose of buprenorphine to a patient on Lopez, Qutipin or oxazepam? Okay, that's a good question. Now, drugs on people on lorazepam, Qutipin and oxazepam, they are essentially needed. A little lower dose of buprenorphine is recommended. However, our main purpose is to control of withdrawals, control of craving, and no added effect of opioid when taken on top of buprenorphine. Once these three goals are fulfilled, the dose of buprenorphine does not matter. These goals can be fulfilled on 8 milligrams of buprenorphine. They can be fulfilled on 30 milligrams of buprenorphine. They can be fulfilled on 20 milligrams of buprenorphine. It is fine by us. As long as the goals of the treatment are achieved, the dose of buprenorphine should not be our goal. Let us not go along with the numbers. The patient should be comfortable. Sometimes when we talk about these drugs, we say that there might be some cerebral depression. So we warn the patient that if you are feeling comfortable, but if you are also feeling excessive drowsiness, if you are feeling that there is breathing difficulty, if you kind of have a loss of consciousness episode on these drugs, then come to us, we will reduce the dose minorly. That means from 20 milligrams to 18 to 16 milligrams. That's it. But the primary purpose of dosing of buprenorphine is control of withdrawals and craving. Once that happens, any number of tablets can be given to the patient. What will be the next option if buprenorphine is contraindicated in a patient or client? Okay, another good question. What will you do if the patient cannot take buprenorphine from you? Now, there are three options available to us. One is that you do not give any drug to the patient. Make the patient go drug-free. But chances of relapse are very high. It is seen that patients who go drug-free, more than 30% patients come back within 1 month with opioid dependence. So it is very difficult for an opioid dependent patient to maintain drug-free lifestyle. Then the other option is giving naltrexone, which is an opioid antagonist. Once that is done, again, you have to admit the patient, detoxify them of all the opioids, then start naltrexone. Difficult process, but once it's done, patient will not need any opioid. However, retention rate on naltrexone are very less. So, in trials, we have seen that patients who go drug-free are only slightly worse than patients who go on naltrexone. The third option that we have is we give the patient methadone. Methadone is a full opioid agonist. It is available as a syrup and it has only to be taken daily dispensing under direct observation. And there are only a few centers in this country that provide methadone. So our basic premise is buprenorphine-based therapy. But in case there is a buprenorphine hypersensitivity, the person cannot take buprenorphine at all, we have to shift to methadone. So in a case that something like this happens in your clinic, find out what is the nearest methadone clinic and refer the patient there. Okay, OST in pregnancy. Good question, Janet. OST has to be given in pregnancy. There are times when we talk about giving drugs being contraindicated in pregnancy. Buprenorphine data is right now insufficient to be classified as a category A or category B. So we have placed it in pregnancy category C. That means from animals, there was no adverse effect seen, but in humans, the evidence is insufficient. So we can, on a case-to-case basis, give the person buprenorphine, which is significantly better than giving the person no drug whatsoever. So yes, on a case-to-case basis, we may need to take that call. Both buprenorphine and methadone can be given in pregnancy. Buprenorphine has some effects, methadone has some effects, but on a case-to-case basis, it needs to be decided what is best for the patient and then taken a call. Any more questions? Any more questions? If not, then I will start asking questions. Okay, now I'll start asking. We have for you some case scenarios over here, which we will discuss. These are something that you encounter daily in your clinic practice, and we're going to see what's going on. A client argues with you that earlier I was addicted to heroin, now I'm addicted to buprenorphine. How will you defend the OST intervention as being provided to the clients?
Yes, ma'am.
Yes, please.
We will tell him that before he was addicted to a bad drug, but now you are under a safe medication. That is what I will be answering him.
Very good. Anything else that you can add to convince the patient to continue treatment?
Of course, like the other benefits could be he used to spend money before, a lot of money, but now you're not spending money.
Right.
And then the other thing could be like he used to take morphine maybe 2-3 times in a 24 hours, but now you're taking buprenorphine only once in a day. So you are happy and you don't have to worry about your next thing. So you can safely go around with your works and your whatever you're doing. And it's a safe drug. So these are the other benefits.
Great. That's an excellent answer. What we can add now is we can tell the person that that was a drug and that could have led to an overdose any point in time. Today you are injecting, suddenly you might die. But chances of buprenorphine overdose are 0. Right? Besides, we have to encourage the patient that once your treatment goals are complete, the dose is being controlled, we
Thorough.
Not audible. Can't hear what you're speaking.
I think something happened to the network, huh? The connection. Was Dr. Gayatri audible? No, huh?
Not audible.
Okay.
Sorry, we
Hello.
had a network problem.
Yeah, we got
Yeah, can you hear me? Okay.
Yeah.
So that was scenario 1. Is when a client who was dependent on heroin is currently taking OST. He's on OST and now believes that he has recovered from addiction. He wants to stop OST. Who would like to answer? Angela, would you like to try? Dr. Angela, would you like to try answering? Okay. There seems to be a network problem. Is there anyone else who would like to try answering this question?
Regarding the scenario 2, how to proceed in this case, can you hear me? Hello?
Yes, I can hear you.
Hello?
Yes, I can hear you.
Okay. I think we have to advise him not to stop the medicine abruptly. We'll have to say to him.
Okay. Okay.
So we've got to taper and explain to him. We have to taper the dose gradually to give the wanted effect.
Okay. Is 6 months an adequate time?
I don't think so. 6 months is an adequate time. At least 1 year,
Right.
I think.
The person should have
in my
taken
opinion.
drug for at least 1 year. Very good. Yes, very good. Now suppose 6 months to 6 years. Person comes and says, I've been taking this medication for 6 years. Please stop my medicine now.
I can't hear you.
So if the person says that I have taken this drug for 6 years now, I want to stop. Will you stop? 6 years is adequate time?
I think we'll have to discuss with him because you cannot stop the medicine abruptly.
Okay.
We'll have to taper the dose
What are the
accordingly.
things that you will discuss? What are the things that will help you form this decision?
To tell him that if we stop abruptly, there will be withdrawals.
Okay, if he says, okay, taper it and stop, is that what you will do?
Yes, I will taper him.
So
I will
every
taper the
patient who
dose
comes and
gradually.
says, I want to stop your medicine, you will stop.
No, I will
In
not
the end,
stop.
it has
It
to
depends on
be
the
the
dosage.
patient.
Disturb.
Okay, will anyone else like to try? Would anyone else like to try? What are the decisions on which you will base your judgment on whether the person should continue his treatment or not?
Can I say one thing, ma'am?
Yes, please.
One criteria could be, besides on regular adherence to the medication, we would like to see how he's performing in his social life, how he's going around in his family.
Very
So
good answer. What else?
whether he is taking up responsibility at home or not, and that is, I think, one of the most important factor. And another factor could be how well motivated he is to stop taking the medication.
Motivate to stop taking the medication. Good answer. There is one thing that we have not taken care of right now. We need to understand what is the risk of relapse in the person's immediate environment. Stop the medication, but he's still going around with his friends who use opioids. There is high chance of a relapse. So along with his treatment goals, we need to understand what is the risk of relapse that the patient is having right now. If the person is at a high chance of relapse, then we will not advise discontinuation of OST. Because we want him to stay abstinent. Now, once the person says that he's not engaging with any friends who have used opioids for some time, he's earning well, he has a good job, his family is stable, there are no psychological stresses that he's having right now. But once his treatment goals are achieved, but there is a chance of relapse, then we can not. At this point in time, we will be putting the person at risk of starting opioids all over again if we take out buprenorphine now. So that decision has to be very careful. Okay. Does anybody have any question about this?
Yes, madam.
Yes,
Can you hear me? Can you hear me?
Yes, I can.
Okay.
Yes, I can hear you.
I'm from Kohima, Kripa Foundation.
Okay, great.
Hello. Yeah.
Yes.
Regarding this scenario too, I would also like to know how long the client has been abusing heroin. If he has been abusing heroin for the last 5, 10 years, then I don't think in 6 months' time no, we can stop the treatment. It is very, very difficult.
Yes,
but,
you are correct. You are correct.
But if he has been on heroin for the last 6 months or 1 year, maybe we can think about tapering his dose if he is willing to give up. So that depends on how long he has been abusing. Number one, how much he has been abusing. Number two, that is also another thing to be taken into consideration. After that, if we see that the patient is sufficiently motivated and he has come to the center because of some genuine family problem or financial problem or health problem, we have to, yes, meaning we can understand that he is very well motivated. In that case, we can seriously think about tapering the dose. So, and if he is doing well, if he has the support of the family members, then we can start thinking about tapering his dose. So, depending on these factors, I would like to consider.
That's a good answer. So 6 months anyway is a very less time. So the person has to take treatment for at least 1 year before we will even consider tapering his buprenorphine down. Now the person has taken treatment after treatment for many years, and when he comes to you, these are all the considerations that we will do before we can decide whether he continues his treatment or we can taper and stop. So good answer.
Thank you. Next.
A client who is currently on daily supervised OST says that he feels much better when he takes 3 divided doses of buprenorphine per day compared to once daily dosing. What is the next step? Who would like to try?
Yes, I would like to say something here.
Yes, please.
Yeah. I think once a day dosage is sufficient and good enough for almost all our clients. But
Yes. Mhm.
there are some who feels that taking it the same dose in divided dose,
Mhm.
2 times or 3 times in a day, they
Right.
feel better. They feel better. That is the way they explain, and I think that is just psychological, because as far as I understand, most of my clients, the once a day dosage works fine with almost all my clients. But there are some who are not satisfied with that. So I think it is just psychological.
So how do you talk? How do you deal when a patient comes and says that he needs, maybe he feels better with 3 doses a day? How do you deal with such a patient?
Yeah,
Do you
we just need
counsel them or do you just send them off?
no. We just need to counsel them. We just need to motivate them and make them aware that this drug acts for 24 hours a day with once a day dosage. We just need to go. But some of them are not convinced with that kind of answer. They think twice a day dosage is better. So
So what
let
do
it
we
be.
do? You let
So
it be.
let it be. Yeah,
Okay.
if he thinks he's satisfied with that, so be it. As long as
Okay,
it's
great.
working fine.
That's a good answer. Also, if the person is not satisfied with our counseling, what we need to do is ask why. Why does the person feels he needs 2 to 3 doses in a day? Most people will say that they need 3 doses in a day because they feel craving or they feel a slight amount of withdrawal coming towards the evening specifically. When the person talks about this, then his complaint needs to be taken into consideration and the dose of the buprenorphine needs to be optimized. The dose in the morning needs to be optimized so that the person continues taking once daily dosing but does not feel withdrawal or craving in the evening. Sometimes dose
One thing,
adjustment needs to be done. Yes.
yes, one thing, madam.
Please.
If he is insisting on the second or third dosage in the evening,
Mhm.
so by the time we will not be there to supervise.
Right.
So there is also that little danger of being misused.
Definitely there. Definitely that's there.
Something we have to keep that in mind.
Right.
So
We need to.
all this, these are some very tricky situations that we
Yes.
encounter in our
Yes, they are
experience.
tricky indeed. That's an awesome answer that you have given.
Ma'am, one thing.
Yes, please.
I feel that if a patient or client is adequately receiving the right amount of dose, it is not possible that he will require medications in divided doses.
Right.
So
there are sometimes chances that the person feels craving in the evening. Now, when that
That means-
happens,
that means-
sometimes we need to adjust the dose, or sometimes we need to provide them with psychosocial intervention like a support. That is either motivation or craving management techniques that will help the person manage his cravings on the dose that we have already given the patient. Because if the dose is adequate, then he should not be feeling any craving. So there are two options. Either we counsel the patient, we tell them that the dose needs to be taken once a day only. If the concern of the patient is genuine, then we address either with therapy or by adjusting the dose. Simple.
All right.
So shall we move on? Okay. A 45-year-old client with opioid dependence and tobacco dependence visits us with the complaint of fever, cough, and shortness of breath. We suspect COVID infection. What do we do next? Who would like to try?
Hello. Hello.
Yes, Miss Flora, please.
In this case, I think we can get the RT-PCR done.
Uh-huh.
COVID test.
Okay.
Yeah, and if it's positive, accordingly, we have to treat.
Okay.
And if he is not on oxygen inhalation, if he's got withdrawal, I think we can give a small dosage of
Okay.
OST.
Okay. But what if the person needs dosage daily but is not able to come to you? If he's COVID positive, then he needs to be isolated, but he also needs his medicine. In that case, what can we do?
But he cannot take orally.
No, he can take orally, but he can't come to you because he needs to be isolated,
Yeah,
quarantined.
so we can give to the person who's taking care of him in the isolation
Very
ward.
good. So we will provide daily dosing to the relative or the family member who is COVID negative. They can come to our center daily, take medication with proper production of ID card of the patient and the attendant, so that we know that this is the patient that has received the medication and this is the attendant that has taken the medication. Medication will still have to be dispensed daily. Clear?
Yes. Yes.
Okay, let's move on. Last. A client on take-home OST followed up at the OST center after 2 weeks. So there's a treatment defaulter. He claims taking buprenorphine given to him regularly. How do we ascertain his claim and assess if there is a loss of tolerance in the individual due to change in pattern of substance use? You all must be
Madam,
seeing treatment defaulters in your OPD, right?
yeah.
Okay, what do you do?
Yes, let me say something here. See,
Yes, please.
for any client, I think we need to bring the family into the picture.
Definitely.
The treatment has to go along with the family, the wife or the whoever responsible family members.
Absolutely.
So that accountability is maintained. Otherwise, you can never trust our clients.
Definitely.
If they are doing it alone, separately, very difficult to trust them. Okay, so we have to bring the family into take the family into confidence. So
Definitely.
this is what I would like to ask: how much he's taking, whether he's doing it properly, whether he is still mixing with other substances. All these small details we need to get to know, and
Yes.
that is and that will also help him to in his recovery if his family members are taken into the picture.
Right, right. So your answer fits very well into this question. We need to take the family members account. We need to ask what these 2 weeks have been like for the patient. And if we are unsure, it is always an option to get a urine drug screen done to see what the last 2 weeks have been like for the patient. Whether there is any illicit opioid use, any kind of mixing of drugs if present will be detected in the urine, and whether the person is regular on buprenorphine.
Yes.
Okay. Anybody else would like to add something to it? Would anyone else like to add something to this? Okay. So with this, we come to the end of our chapter, of our discussion today. This is the take-home record sheet. I gather you are all familiar with it. Are we fulfilling such a record sheet in our centers?
Yes, we do have this sheet.
Okay, that's great. So this is the end of the discussion. I will stop sharing my slides again. Okay. Anybody else would like to ask me anything now? Okay, then Moong, I hand this over to you. I think my bit is done.
Yeah, so thank you very much, Dr. Gayatri. Um, We have actually finished quite early.
Yes, we have.
Exactly on time. So I would like to request if the participants have anything else they would want to ask. Any more questions? Any doubts? Anything? We have not heard from Meghalaya except for Dr. Flora. Any questions? Maybe for another 5 minutes.
Excuse me. Hello.
Yes, Dr. Flora. Can you hear me?
Hello.
Yes, Dr. Flora, we can hear you.
Yeah. I said in the case of a patient who has completed the treatment on OST, is tablet naltrexone compulsory?
Hello.
Dr. Gayatri, were you able to catch her question?
No, I think I lost her in between.
She was asking, I think, regarding naltrexone. Yeah, Dr. Flora, do you want to repeat your question?
If not, she can write in the chat. I can read from there.
Otherwise, then before we end, maybe Dr. Gayatri, you could talk about how we can reduce our irregular client irregularity or dropout, and then how we can improve
Yes.
retention of clients.
So loss to follow-ups happen in every clinical practice, right? And it is a very painful thing to see your client lost to follow-up and then coming back with a relapse. Thus, it is very important on our parts as doctors to not only monitor that the patient is being given medication regularly, but also to monitor what our other staff is doing. Is he being counseled well? Is the nurse behaving well with the person? Is the staff cordial? Is the information that he is being given correct? Is the center welcoming and friendly? Does he feel safe with us? Once the client is happy being in treatment with us, he will continue to be in treatment with us. If there are any other problems that the client is facing coming to us, or maybe it takes a long time for him to come to us and be given medication, if the person does not share a proper relationship with the staff that is taking care of them, then the chances of falling out of treatment are very high. Thus, as doctors, we need to have a good rapport with our patients. We need to talk to them regularly. We need to ensure that they are comfortable and happy and satisfied with the treatment that they are getting. And we need to ask them what questions and what doubts they might have regularly. Once we do it, then our clients will stay with us. Also, something that I would like to tell all the medical officers is that addiction is a relapsing remitting illness. So sooner or later, it is going to come back. If your client falls out of treatment and comes back to you, do not feel that your problem is doubled. Do not feel that your treatment has failed. It is just a part of the illness. It is a part of the illness to fall out of treatment, and it is a part of the illness to come back to it. So, every single day that the person has not taken drugs is thanks to you. So all we need to do is just increase the days where he does not take drugs. If a person falls out, it does not mean treatment failure. It means that this is an opportunity to learn something more and provide more help to the person. If we work with this attitude, we will never feel that we have failed, because treating an addiction patient is difficult. And even if we manage to make the person abstain from drugs for even a day, it is a cause to celebrate. Okay.
Yeah, thank you, doctor. To supplement what Dr. Gayatri was saying, I would just like to add a few more words. For the NARCO program, is OST is one of our most effective harm reduction strategies. So we have given research quite a high target. Like we want to put, if you have 100 IGUs, we want to put at least 50 of them in the OST program. So we are trying to achieve those targets. So in this case, we are highly dependent on you guys, the doctors, our medical officers, to help us in achieving this target. We need you to be available. We need you to help us in induction of new clients. And then, like Dr. Gayatri has said, we need you to be overall in charge of the OST centers, looking at what the nurse is doing, what the counselor is doing, what the NGO, what is the ORW doing, what the data manager is doing for NFP training. We need him to please take more responsibility to be overall in charge. We need the OST centers to perform well under your leadership. So this is my request to all the OST central medical officers. And so we want to thank Dr. Gayatri once again. It was a very, very nice lecture. And then thank you for the participation also. We had very good participation.
Thank you, everyone.
And then, so what we will do is we will add all of you in the NARCO OST medical officers group, and then Dr. Gayatri and will also be there. And then if you have any further questions, please reach out in that forum. And I know in Meghalaya also we have Dr. Rita Lamar. She's also one of our master trainers. She will also be there. So this is it for me. Unless our JDTI wants to say anything. Wilson, do you have any last words? Yeah.
Mung. Hello.
Yes,
Dr. Wilson.
I'm not the doctor. Actually, Dr. Janet is asking, can she join again in some other batches because her network is very bad today.
Yeah, no issues. We have Assam, Tripura, Arunachal coming up. Then we will give her the list. Okay.
Fine. Thanks, doctor.
Okay, then thank you all very much for joining. We are very thankful, and thank you, Dr. Gayatri, once again. So we'll
Thank you, everyone. Thank you. Do you want to take a picture now? Like we did last
Shall we
time?
take a Pravinji, can we have a group photo, please? Yeah. If everyone can on their videos. Yeah. So Praveen, just let us know once it's taken. Yeah, please turn on your videos, please.
Hello.
Yes, Dr. Flora.
Hello. Yeah. What about that question which I asked? I just want to be clarified regarding naltrexone.
Yeah. Tell me. You asked whether a patient who has completed OST treatment is naltrexone compulsory, right?
Yes, that's the one.
Okay. So prescribing naltrexone is ideally a choice after OST has been completed. But studies have shown that as compared to no drug versus naltrexone, chances of having a relapse with no drug are greater. So it's not compulsory, but it is preferred that a patient who has completed OST is given naltrexone.
Okay. Thank you so much.
Can I comment
Thank
something
you.
there? Doctor? I know we are over time.
Yes, please.
Yeah, for those person who wants to give up completely, yes, giving naltrexone, yes, psychologically it helps, but I would say that the best advice that we can give is, as you have tapered it to the most minimum, you can advise him to stay in a rehab for 1 month or 2 months, whatever. That helps him also to give up and helps him to cope with the slight withdrawal that he will experience. This is my usual method. That's my advice.
Yeah, so Praveen, have we taken the video or are we done? Okay, then I think we're done. Yeah. So thank you all. Yeah. See you
Thank you,
again.
everyone.
Okay.
Thanks. Okay. Bye, everyone. Bye. Katie.